Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
What should the average dental treatment coordinator's day look like? Or even better, when a treatment coordinator isn't working with a patient during a consultation or making financial arrangements, what should they be working on? To that end, I get this question frequently from our clients here during seminars or from their treatment coordinators that they've brought with them. When I'm not with the doctor doing a presentation, where should I be placing my focus? Well, to understand that and to ensure your treatment coordinator has the best shot at being successful, it takes a basic understanding of the position itself and its purpose. And then, of course, it's easy to understand what the average treatment coordinator's day should look like. And that's what I want to talk about in this week's episode, the treatment coordinator day-to-day duties and functions. My name is Jeff Bloomberg, and I'm your host. And the best place to start is by taking a look at this position of treatment coordinator and comparing it to other businesses to figure out what would be the corresponding position in another service-type business. Well, the answer to that is very simple. It's a sales job. The job of the treatment coordinator is to sell. If you were to take another business that sells some type of service, whether it's roofing or car repairs, and I'm not trying to compare healthcare to these things, but it's a function. It's something that has to be done. You need someone there. It might be an estimator who sells your roofing job or something like this. Someone has to actually figure out what the person needs, which is really up to the doctor in a dental practice, but then someone has to work out how much it costs, get them to close, and get them to pay for it and contract it and things like this. That's the job of the salesperson. And I know when you mention sales with relation to healthcare, it's not as bad as it used to be. It's almost as if it's a taboo word. You don't want to say sales because we don't sell in healthcare. Well, sure you do. If I come to see you and I need, 6 crowns, and I only want to do what insurance covers, but I really need those 6 crowns now, I should be sold to get me to understand why I need all 6 so that I do them. That's actually better not just for you. You're not going to only make more money, but it's better for me from a health perspective. And sales really isn't all about just getting money. If what you're doing is beneficial, it's actually about helping a person to obtain the service or product that they actually need. You're not selling, terrible things that are going to destroy the person. You're selling healthcare. You're selling the ability to be healthier and improve their quality of life. This is a good thing. So you're helping them to get the help that they need. And how is that achieved? Education, communication, helping them to overcome objections, etc., and getting them to pay is part of the process. And I believe that's where most of the focus goes, because people get a bit crazy on the subject of money. You've probably seen this when you're talking to a patient and they seem completely fine. And then you begin discussing the fees associated with their treatment plan. And it's almost as if they've had a personality transplant at that point. What happened to this sweet person who was sitting in front of me that's now looking at me with daggers in their eyes? People get a bit, emotional about money. And I think that's why part of it, and plus, money is an important function of life and society and business. So all this focus goes on money. But you should really look at the money part of the case presentation and acceptance as just another step. The person has to pay so that you can adequately provide the service and be able to pay your staff and keep your practice going and things of this nature, just like they have to schedule and show up to get the service. They're of equal importance in the process, just like they have to show up for you to be able to diagnose the treatment. It's just another step. So I think sales gets boiled down to, it's all about the money. Let's get the money. But it really isn't what it's all about. From a sales perspective, yeah, you have to get the person to pay, but it's just as important to make sure that they actually arrive or receive the service or product that you sold them. And caring about your prospect is an important part of this. If I actually care about my prospect, or in this case, your patient, then I'm not going to sell them something that they don't need or that isn't going to help them. Think about it for a second. The sales area of sales that tends to get a lot of pushback. Let's say car sales, for example. We don't want to deal with a quote-unquote car salesperson. Well, what if a car salesperson had you come in and asked you what you were looking for and what needs it needed to fulfill? Maybe you have a large family and you need a larger car for everybody to fit. You want everybody to be safe and it has to be durable and things of that nature. And they found the exact model that fit your specifications. Well, Yeah, sure, you're going to have to pay for it, but they cared enough about you to make sure that you got what you needed. So care is an important part of sales. It isn't just about getting the money. So on top of this, though, with relation to sales, I've trained a lot of salespeople. It's not just a matter of closing. Closing is just one part of sales, or even presenting is just one part of sales. You have to make sure that there's people in front of you to actually close. And you have to make sure that there's an adequate number of people in front of you so that you actually are closing enough to support the business, if that makes sense. So if I'm a treatment coordinator, I'm a treatment coordinator, and I'm supposed to collect, $50,000 this week. Well, then I have to make sure that I have enough patients that we're actually presenting to, or there's enough treatment in those cases. There's patients with adequate amount of treatment in order for me to meet my goal. Obviously, I'm not going to create treatment out of thin air. They either need it or they don't. But that's part of the job. It's lining up to make sure I have an adequate number of presentations, and then I do these number of presentations so that we can actually get the closes we need for the business, but also we're getting the closes on the patients because we're helping to restore their health. You see? So with all of that in mind, if you were to look at the purpose of a treatment coordinator in a dental practice, it is a sales job. It's to help all of the practice's patients who have outstanding treatment to understand, accept, pay for, and arrive for their diagnosed or needed treatment. That's really what it is. So if I'm your treatment coordinator, my job is I look at the entire patient base as a whole, and everybody who has outstanding treatment, my job is to make sure they get in this practice and get that treatment taken care of. Now, am I going to get everybody through all of their outstanding treatment? That's a bit of a tall order. It's a work in progress, but I'm always working towards that ideal. Do you see? That's the reason I'm there. That is my function. That's why I exist, to make sure that your whole patient base is coming in here and getting the treatment that they need. And the really cool part about all this is, in a dental practice, if they actually get all this outstanding treatment that they need and we restore their health and function and aesthetic in cases where it's important to them, well, especially with health and function, that's going to improve their quality of life. I mean, aesthetic would as well. It's also, in many cases, going to help improve their systemic health. They'll live longer in many cases. I know you can't guarantee this, but you know the studies I'm referring back to. There's plenty of studies linking dental health or oral health to systemic health. So this is a great outcome, not just for the practice, because we're treating all of these patients, but it's an excellent outcome for the patients themselves. And this is something that any treatment coordinator should think about if someone is giving them a hard time. You're there to help. Unfortunately, not everybody appreciates the fact that you're trying to help them. You presented a treatment plan and someone yells at you and says you're just money grubbing and you're just after the money. Well, two things to know. One, not everybody feels that way. They do, but that's fine. But two, most people really appreciate the fact that you're there and you're actually trying to help them. Part of helping people in some cases, especially with a dental situation, is, a lot of dental situations develop because of procrastination. People aren't dealing with it when they should. So that's part of what you're having to overcome when you're trying to move this person along to taking care of it. So they've developed various types of dental disease in their mouth. They have a few teeth that are in trouble. They need a few root canals and some crowns. Well, they didn't always need those, and had they been taken care of earlier, they wouldn't have turned into root canals. They would have just been crowns, and had they taken care of earlier than that, they just would have been fillings. So that sort of procrastination, that unwillingness to move off the dime, is part of what you're helping them through in order to confront and handle the treatment that they actually need. So I say this only because, and I've said this to clients before, if you're ever having a bad day, things just don't seem to be going right, the collections are terrible, you can't figure out what you should be working on, well, just focus back on why you're there. That's always important, and just help some people. You're going to help all these patients get back into ideal dental health, oral health. That's your job, because it's going to positively affect them in their life. Find someone to help and just place your focus there. That'll work you out of more jams than you can possibly imagine. So if the treatment coordinator's job is to help your entire patient base get to understand, pay for, and schedule arrive for their outstanding treatment, then how would you staticize this job? Well, generally, being that this is a sales job, the treatment coordinator's statistic is income, practice revenues. That would be their stat. So if you have a treatment coordinator, the overall collections for the practice is their statistic, okay? So with this in mind, what would their average day look like? How would it go? Well, The first thing to know, again, is their statistic is income. So where does income come from? Well, in your case, it comes from closing cases. You have to deliver those cases, of course, but that's the doctor's side of this, the stick here, right? So to begin, if I'm a treatment coordinator, I would start with a goal for the month, or I would actually break those goals down by the week, most likely. If you start for the month, really staying on top of who you have to see and what you have to do becomes a bit difficult. I would start for the week and I would monitor it day by day. So let's say our goal for the month is, $200,000. So that means I need to somehow figure out how to collect $50,000 this week. So that's where I'd start. So where I would look at is I would look at what does the coming week look like? Who's coming in and who needs what? And this is where I've mentioned this in prior episodes. We have something called the morning production meeting. I'll put a link to it on the episode webpage. This is a coordination meeting in the morning that you do with your key personnel to figure out what patients have outstanding treatment and who's going to help present that treatment. All right, this is a critical part of increasing your income and putting some control on it. So the treatment coordinator would be looking at this, who's coming in on these days. And where would they be looking? They'd be looking at hygiene and the doctor's schedule for any outstanding treatment. It's a bit difficult. We call this lining up your week. You're doing your lineup. Oh, here's Mr. Jones. They're coming in on Tuesday. They have 4 outstanding inlays. Okay, so if I close that case, that's $4,800. You see? So they kind of line up where they're going to get that $50,000 from this week. A little bit of a trick with lineups is if you want to do it line up effectively, always line up more than you need because not everybody is going to close. In some cases, I recommend lining up 3 times what you need. And you'd be surprised how much treatment walks into your practice and just does not get done. If you don't believe me, look at your hygiene schedule. It's there. So then I would do that lineup, and then on a day-to-day basis, because schedules do change, I would take a look and make sure my lineup's intact. It's very difficult to, unless you have a new patient from like an implant funnel or something like this, it's very difficult to use a new patient like with an amount on your lineup because you have no idea what this person needs. I may call in and say I cracked my tooth and it's really just a tiny little chip, which is a teeny little composite, which isn't really much of anything, or I may have broken my tooth in half. Until you've seen me, you don't really know what I need. So then you do this on a day-to-day basis. You're doing your lineup. So then from there, the treatment coordinator's duties would consist of, in addition to lining up their week or day, 9 basic actions. They do their lineup. They would meet with patients on an as-needed basis, depending upon when a treatment presentation is happening. And I should mention this here. The way we teach our clients here at MGE to sell is the doctor is responsible for the sales process. I mean, obviously, you wear several hats in your practice if you own your practice. You have your owner hat, which is your executive hat, and then you have your doctor hat, and you have your sales hat. And if you, again, look at every hat in an organization or job, they all have different expected outcomes or results. So the result you'd expect of an executive might be an expanding organization. The result you would expect from a doctor would be a properly done treatment or a well patient. And the result you'd expect from a salesperson would be closing. So the sales team is the doctor and the treatment coordinator. As I progress through the episode, I'll give you a couple of variations on this. But generally speaking, when it comes to a treatment presentation, the way we teach our clients in the beginning is to present the treatment to the patients with the treatment coordinator there. Now, why? Because the treatment coordinator, by sitting through the consultation, will know how you handled various objections that the patient may have had. Because those objections may come up again when you leave the operatory or the consult room, or I leave with the patient to go work out financial arrangements, and they may bring up that same exact objection. You told them they needed 6 crowns, they agreed to it, they come back to my office, and now they tell me, well, what's insurance going to cover? Just 2. Let me just do the 2. Well, maybe they said that to you when you were doing the presentation, and I heard how you handled it. I can just repeat the same thing, and in many cases, handle that objection just like you did. So ideally, the treatment coordinator is there with you for the entire presentation and goes off to work out financial arrangements. I'm not going to get into the entire sales process. I've detailed it in prior episodes. But again, the doctor should discuss fees in this presentation, how involved you want to get with it. I don't have the episode numbers in front of me. Sorry, full disclosure. But there are several episodes I've done on treatment presentations where we discuss how far the doctor can go with the financial discussion, a little bit or a lot. But minimally, what I would expect at minimum is the doctor is going to mention the cost. And then they go off with the treatment coordinator to work out wrapping it up. The treatment coordinator works with the scheduler to get them scheduled. And then it's important to the treatment coordinator that the patient actually shows up to begin treatment. Because in many cases, especially if the patient's financing or prepaying, that's a liability to the practice until the patient shows up. And again, back to the purpose, what this is all about is getting those patients to get the treatment that they need. So great, I got paid, but now I want to make sure that the patient actually got what they came here for, which was treatment. So the second the patient is sitting in your chair to actually start this treatment that we've closed, my job as the treatment coordinator with that patient for now is done. So it starts from the beginning, from when you diagnose it, through the presentation, the understanding, the financial arrangements, the closing, the scheduling, and then getting them to arrive. That's essentially what my job is as the treatment coordinator. So back to these 9 points, I have my lineup that I do on a weekly basis. I have my meeting with patients, as an example, during consultations. Now, if I'm not meeting with patients, what am I working on? Well, the first thing would be following up on recent presentations for closes. And these would be more maybe just one little thing needed to be handled in order to close this case. So the patient said they had to go home and talk to their spouse, and there was no way to get the spouse back in. The spouse didn't want to talk to the doctor. So I would follow up on that to make sure that it resolved. Or the patient was refinancing and they had to wait till they were done refinancing in order to pay for their treatment plan. So those are the type of follow-ups that I would be working on initially. The idea is, in many cases, if I have a patient who's starting to wobble as the treatment coordinator, meaning, you presented the case as the doctor, I sat in with you, we got it to the point where the patient wanted to do it, but then hit the brakes because they had to wait till they spoke to their spouse. And then they go home, and they've now talked to their spouse, and their spouse is a bit tepid on them doing it. Generally, what I'm going to attempt to do in those cases is get the patient back into the practice, or at least, nowadays, there's things you can do virtually. Even virtually, we do a lot of consultations virtually and a lot of practice analysis virtually. It's never going to be as good as when you're in person. And being that you're a local business, many of our clients are all over the country, so in some cases, getting them in front of this is not 100% real at that moment, but you're a local business, so there's no reason that you can't get the patient and their spouse to come back in and talk to the doctor again. These things are usually resolved best face-to-face as opposed to over the phone. So let's say I called this patient, they talked to their wife, they didn't want to do it. Well, I'm going to try and see if I can get them scheduled to come back in with their wife to talk to the doctor. So those are the immediate follow-ups that I'd be doing. Now, when I'm not doing immediate follow-ups and I'm not doing treatment presentations with the doctor, what am I working on? Well, at that point, what I'm doing is I am outflowing or communicating to the patient base. So now, which portion of the patient base would you want me focused on? Keep in mind what the purpose of my position is. My job is to get all of your patients with outstanding treatment to get that treatment done to restore their oral health function aesthetic, which then contributes to better overall health, longevity, etc. Well, you're going to want me focusing on patients who have outstanding treatment. So I have no one to see right now. I have no follow-ups to do right now, immediate follow-ups. So now I have that incomplete treatment list, which it's great that software keeps track of these things. But the utility of this list has not been very good. I say that in the sense of I've seen people advise that when you have openings in the schedule, you should call your incomplete treatment list. Well, ask your front desk or ask your schedule coordinator or any of the administrative staff in your practice, if they've ever called that list before, how useful it was. By survey, I know it isn't. I could tell you from seminar to seminar where I bring this up. It's not very useful. Why? Because a patient on the incomplete treatment list isn't closed on doing the service. That's ultimately what it is. You presented a treatment plan to me, and for whatever reason, I elected not to do it right now. I was not handled to, I didn't want the treatment enough to proceed, or my objections weren't addressed enough to proceed. So now you're going to call me and say, hey, Jeff, are you ready to do that treatment now? 9 times out of 10, maybe even 99 times out of 100, I'm going to say no, I'm still thinking about it, or I still have to, I don't have the time, or I'm very busy, or I can't afford it, or whatever objection I'm going to give you. You will occasionally, once in a blue moon, that's funny you called me today. I was just thinking about it. Yeah, I would like to proceed. That's the unicorn. That does not happen very often. So what ends up happening is you have this incomplete treatment list, and it just gets bigger and bigger and bigger, and you look, and there's all these lost opportunities, and some doctors will total their lists up because the software will do it for you. Well, my incomplete treatment list is $2.8 million. I was talking to an office recently that it was over $6 million. This is treatment that you've diagnosed and have not done. So that incomplete treatment list should be the purview of the treatment coordinator. This is the person who is working that list. So how do they work that list? Well, let's I know I'm kind of backtracking here, but let's say we've gone through my day. I don't have a patient to see right now. I've done my immediate follow-ups. I got my lineup. Well, then what I would do is I take that incomplete treatment list out, and I would just start calling it. I might order it by bigger treatment plans. I'm not calling the patient who needs one occlusal composite right now. I'm starting with the bigger cases probably, and or the more urgent cases. And I'm going to take a look at this patient's chart, and I'm going to determine A, is this patient due for a hygiene appointment, or B, is this person not due? Let's say this person is due or overdue for a hygiene appointment. Let's say they're way overdue, 3 or 4 years overdue. Well, I'm going to call that patient, and I'm going to schedule them for a hygiene appointment. You might say, well, that's counterintuitive. Why would the treatment coordinator schedule a patient for a hygiene appointment? I have a schedule coordinator to do that. Well, I'm scheduling a patient with a large outstanding treatment plan for a hygiene appointment. That makes sense because I'm getting them back in the practice. Action happens when we get them back in the practice. That's when they close. That's where we're going to treat them. That's where we're going to take care of their dental problems. Nothing is going to happen outside of the dental practice, so I want them back. So in those cases, I might schedule for a reinitial or something like this. And now we have that opportunity again. They're back in the practice. We get some updated x-rays, charting, scans, things of that nature, and you can look at what's going on and adjust the treatment plan as needed, and we can present it then and there. So that's what I'm doing with patients that are due or overdue for hygiene. I'm just getting them back on the hygiene schedule. Now, what about a patient who maybe you presented, let's say 4 months ago, so it's not recent, and the patient just said they wanted to think about it. Maybe they're scheduled for another 2 months from now for their hygiene visit. Well, I could do one of two things there. One, I could do nothing and wait for them to show up in 2 months for their hygiene visit. Or two, I could call those patients and schedule them to come back in for a brief consultation with the doctor because you want to make sure that everything's staying stable. Basically, what I'm attempting to do is get that patient back in, stick them in front of the doctor again, so we have that opportunity to present that treatment plan again. This is very reflective of what I was discussing, I don't know how many episodes back this was, probably 6 episodes back, where we found that some practices were putting this huge focus on with new patients. You present that treatment plan, you diagnose it, you present the whole thing. But let's say you presented that treatment plan to a new patient and they didn't accept it, and then they come in for their recall, and then they come in for the next recall, nobody presents treatment again. Or you had a patient in recall, you presented a treatment plan, they said no. Well, they come in for their next recall, nobody presents a treatment plan. Like we do it once and that was it. Like they're going to just say no because they said no 6 months ago. It's a bad way of operating. Every time you encounter this patient, there should be a discussion until this treatment is completed. And you can do that in a way that isn't cheesy or pushy because again, what is our object? We're trying to improve this patient's health. So that's what we're doing here. We're either getting patients back on the hygiene schedule as the treatment coordinator, or if they are not due for hygiene, we're getting them back for a quick, look-see with the doctor to make sure that everything is staying stable. Most likely, when you start working the incomplete treatment list, you're going to have a ton of patients that are overdue and unscheduled, tons that are on that incomplete treatment list. Most likely, what I would focus on, if I had a bunch that were unscheduled and I had a few that were scheduled and they were coming in the next month or two, I'd probably focus on the unscheduled at those points or that point because I'm going to be seeing these other folks on hygiene in the next 1 to 2 months. And then on top of that, so I've got my outflow to the patient base. What other things would I have that would my day consist of? I'd have any administration, admin I'd have to do, any contracts I have to fill out, chart notes based on the financial arrangements and discussion with the patient. And I'd had to attend the various coordination meetings, the morning production meetings, staff meetings, etc. Those are the 9 basic things: lineups, meeting with patients, following up on recent presentations, outflowing to the patient base, calling patients on the outstanding treatment list, getting them in for recall, or getting them in if they're not overdue to see if it's stable, and then coordination meetings and administrative stuff that I have to do. That's essentially my job. What I've described to you in essence, if I had a salesperson working in a service-based business, that would essentially be their job too, because that's what this job really is, and that's pretty much what it is. Now, a couple of things to look out for. Let's say I'm the treatment coordinator, and I'm spending all day in these patient meetings, either doing financial arrangements or helping with consultations, and I have no time. I can barely do the follow-up that I have to do on recent presentations. I barely have enough time, and I have zero time to follow up on the incomplete treatment list. That's a problem. Your business is missing an opportunity here, and that means you don't have enough treatment coordinator time. So this is where you have to get smart about this. Maybe you don't need another full-time treatment coordinator yet. Maybe you need a part-time treatment coordinator. And to that end, what ends up happening in a lot of practices, the treatment coordinator is usually the office manager initially, doing it in addition to their office manager duties. And then eventually, after they've manned other positions, financial coordinator, scheduler, etc., the treatment coordinator job is the last position that they eventually turn over because sales is a little bit more, I hate to use the word difficult, but it definitely, maybe difficult's the right word. Closing's a little bit more difficult than scheduling. I'm not saying this isn't any type of a diss to the schedulers out there at all, but it takes a little bit more training to be effective at it. But that's usually the last job that the office manager turns over because also it's directly linked to business income. So let's say I'm the office manager and I find myself spending 4 or 5 hours a day sitting in on presentations. Well, I probably need to hire a treatment coordinator. So I'm going to eventually have to apprentice this person up until I can get them to the point where they can close. So I'd be doing that as I'm doing my presentations, but then the rest of the day, I would have this person working on these follow-ups most likely, or getting these patients back on the hygiene schedule because then they're going to create more opportunities. Do you see? So me being a treatment coordinator part-time while I apprentice this person, and this new treatment coordinator I've brought in who's now full-time, almost equates to about 1.5 treatment coordinators. Now, once I put this treatment coordinator on the job, there may be cases where we have, times where we have 2-3 patients who need a treatment presented at the same time. Well, fine, then we're both on deck, right? We're both doing it together. But this is something you want to look at from a resources perspective as well as a time perspective. If your treatment coordinator does not have time to do follow-ups and call the incomplete treatment list, you're missing a large opportunity and you do need more treatment coordinator hours. How you figure that out really depends on your individual situation. Now, also, I mentioned I was going to discuss this a little bit as I got towards the end of the episode. Let's take a look at how the treatment coordinator integrates into the practice for a second, just specifically on this closing aspect of things. Generally, the treatment coordinator works with the doctor. You ideally want the treatment coordinator there with the doctor while the treatment plan is being discussed, as I mentioned earlier. Now, that's more important with a newer treatment coordinator than with a more experienced treatment coordinator. For example, if I'm presenting a $4,000 case and I have a treatment coordinator who's just dynamite, we've worked as a team for years and we know exactly what the other one's thinking half the time, and that treatment coordinator happens to be in another presentation that they're wrapping up right now, I could probably start this presentation myself. Let's say the office manager isn't available either to take over in case I get done before the treatment coordinator's done. But I could start this presentation myself and then walk the patient over to the treatment coordinator when I'm done, assuming that he or she is done with the patient they were with. Turn it over in front of them. Hey, here's Mr. Jones. He needs X, Y, Z. And leave the room. And the treatment coordinator knows how I handle things and should be able to close. A more experienced one will be able to do that. A newer one may not be able to do that. They're not really with it yet, so that's a bit of a problem. So ideally, you want them there with you. And then as this develops, you could, for example, let's say you bring in an associate doctor and you have that associate diagnosing treatment. You're not doing it all yourself. Or let's say you're out of the country for a month or something along these lines. Well, if your treatment coordinator is a really good closer, that associate, as long as they can explain the treatment and answer the patient's questions, even if they don't have the sales training yet to get into fees and things like that, which they should, then they can pass that over to that treatment coordinator, and maybe you won't have as good of a close rate as they would have with you, but you'll at least get something, which is really good. The ideal situation is that the doctor and the treatment coordinator should both be able to close. They should both be able to close. And again, closing is only a part of this. There's a lot of other actions, as I mentioned. which all have as their object, like, why am I lining up my week? Why am I making all these calls for follow-ups or to get patients back on the schedule? It's to create more opportunities to close. And again, the object of these opportunities is to improve patients' health, so this is a good thing. Now, if you don't have a treatment coordinator and you're thinking about adding one, and this is an interesting thing. I was talking to Dan Brown, who you've heard on the podcast before, especially with the marketing episodes. He's a partner at Bloomberg Digital. He's also a senior consultant here at MGE. There are a lot of positions that we've looked at, well, those are positions for larger practices, or that's a luxury or something along these lines. I agree in certain cases. In a smaller practice, the office manager might be double-hatted, so to speak, as the office manager and the treatment coordinator. But there's certain positions that you might want to really look at the amount of what you don't see can hurt you here. You may be missing, for example, a lot of new patient opportunities. I know I'm kind of going off the rails here. Let's say you're getting a bunch of phone calls, you're not converting them because your receptionist is so busy that they don't have time to breathe. And they're putting patients on hold every 5 seconds because they have another person walking up to the front desk. Well, you might benefit from a new patient coordinator. Or you find that you have 4,000 or 5,000 inactive charts. They're just sitting there. Nobody's calling these charts. You might benefit from bringing somebody in to actually call these patients. Same thing applies with the treatment coordinator. You might have millions of dollars on your incomplete treatment list. You might have 3 or 4 treatment presentation opportunities a day that nobody's really has the time to do, in which case you might actually need a treatment coordinator. If you are hiring a treatment coordinator, what are you looking for? You're looking for somebody who's smart, driven, a good communicator, and has no trouble discussing money and having people pay them. The reason I say this is some people view money as this huge taboo subject and they just can't discuss it or they feel uncomfortable discussing it. That's not a good idea. And being that you as the doctor are also a salesperson, you should be comfortable doing that as well. And in the long run, actually in the short run, I would always recommend that the doctor and the treatment coordinator have some sales training. To that end, we have our MGE communication and sales seminars, which are just dynamite. I'll put a link to them on the episode webpage where you can find out more. We also have, to give your treatment coordinator a little bit more orientation, on our online training platform, DDS Success. We actually have a whole treatment coordinator training course. And if you want, you can get a free demo of the platform. If you want to check it out, I'll put a link to it on the episode webpage. And if you're a podcast listener, mention it to the person giving you the demo, and they'll give you a special $20 a month discount. It's usually $289 a month. We give it to you for $269. Anyway, so that's about all I have on that. I know kind of ran on and on and on, but I wanted to give you an idea of what this job should look like, because we tend to just focus on just the one aspect of the job, presenting treatment. And there's really so much more. And trust me, in your practice, if you have a treatment coordinator, you probably have more than enough things to keep them completely busy. And if they really do their job well, a lot of cool things happen. You collect more money, you're more profitable, the practice expands, and most importantly of all of this, you end up with more healthy patients. So that's all I have for you this week. If you'd like to know more about MGE, you can find us online at mgeonline.com or call us at 800-640-1140. I have those links on the episode webpage, which includes the links for DDS Success, the MGE Communication and Sales Seminars, and the morning production meeting. I would definitely check those out. The morning production meeting is a free download. Feel free to download it. It's useful. If you have questions, you can always email me at jeffb@mgeonline.com. Folks, I hope all this helps. Have a great week, and we'll see you at the next episode.